All right, I want to get back a little bit because with OCM, and we've talked a little bit about pathways and other initiatives that are all part of it. Susan, it seems as if practices are changing what they're doing, from a patient advocacy perspective, there would need to be some declaration that we're participating, not just we're doing better. Now, on the one, you could say that a practitioner would say, I've always followed some kind of a pathway. It's an in-house pathway. It's the pathway that I was trained in at where I trained, or it's NCCN guidelines. But it is a bit different in OCM. So what is the guidance that practices are given, if any, and who provides that guidance? How do you approach this process? If you're truly patient-centric, how are you communicating that we're in this program?
That's right. Well, that's one of the fundamental things that those OCM practices need to do. They have to tell the patients that they're being enrolled into what is called the Oncology Care Model, and
But there's no formal consent they're signing to do so.
That's right. But there is an approach where everyone should be receiving a letter, a information guide, and each practice has been challenged to decide how that's going to be rolled out. But that is absolutely, everyone needs to needs to demonstrate that they've given that to the beneficiary. Some practices are using their navigator up front, and they are sitting down with those patients and describing what OCM is and isn't. Other practices are sending a letter. And so you can imagine that there's going to be really different outcomes with those two sorts of practice. One that's more dynamic and engaged, and one that's a little bit more passive and checking a box. Yeah.
So I would wonder, and I'll go back because we've got the clinicians here too, that Rich, if they're participating, now they're going to be measured in an episode of care. Is that concept even described? Is it necessary that they're being measured in some way, that they're being assessed, or that there is an assessment based on a 6-month period? Or I'm putting you in this therapy and and the 6 month is kind of irrelevant to what I'm doing?
I mean, the 6 months is, in my mind, a fairly arbitrary number, and doesn't really actually capture the kind of the history and the natural course of the disease, or kind of how we practice. So that's not something that I emphasize in any way. You know, the goal is to kind of capture, are we actually making things better? But the time period, in my mind, is a little bit arbitrary, and it's not something I talk to my patients about.
But Kavita, it's not arbitrary from the standpoint of the metrics that are by which the performance is being measured.
Right, the measurement period is 6 months, so it's not, it's arbitrary in a very true clinical sense. It's not arbitrary from a payment sense.
So there are a lot of great minds that were wrapping their heads around this. And what was the thinking, if you know it all, because you probably sat in some of the interesting conversations, as Rich was talking about the fact that he now sees melanoma patients who he's thinking about cure, even though they're metastatic. And how do we think about the cost of a 6-month episode, where that choice made about that 6-month episode could relate to 3-year, 5-year, 10-year survival differences? How is, where in a different system, or in a different business line, you would amortize that cost over the duration of the benefit. Mm-hmm. But here we're kind of looking at it in this kind of arbitrary way. But I'm sure that people talked about it and thought about it. But medicine is changing quickly, in light of the novel therapeutics that have been introduced.
So Ted will tell you that, because he was in some of those rooms and nobody talked about it. So I don't think it was because of any malicious, explicit desire to not think about it. I'll just be honest. I mean, even from when I started my training, and it now feels like a long, long time ago in a galaxy far, far away, but we didn't have much beyond platinum. I mean, there just wasn't much to give to patients. So for policymakers who have zero clinical expertise themselves in general, to kind of think through that, I would say the one thing that CMS did is this novel therapy adjustment, and a lot of the immunotherapies that have emerged kind of fall into that category. So the one policy thing that I do think was the first step at what you're talking about, Bruce, was to actually say, listen, we get that in cancer there's lots of new drugs, and we're going to treat the prices of those new drugs a little differently, so that what they were trying to do is nuance, not having a doctor feel like they shouldn't prescribe life-saving therapies just because they're new and costly. But then they also wanted to kind of recognize that we don't want to just say, go prescribe anything you want regardless of the evidence. So that was what they were trying to thread.
But the interesting thing is that when this was developed and devised, they weren't thinking about the impact of the IO drugs.
And the survival.
The cost of the IO drugs.
Correct.
And they weren't even thinking about, as Kavita said, Bruce, what you're talking about is 3, 5, 7 years down the road in terms of survival. So what's kind of interesting about it, even though Kavita is absolutely right in terms of they put in this novel therapy adjustment to take into account these novel therapies, they didn't have any indication of the impact that basically the IO drugs would have. And as a result of that, price prediction is a big problem with this model because the underlying prices do not reflect and are not adjusted enough for some of these new therapies, specifically in terms of IO. So it's a real problem in that you've got a program that I know practices that have done an amazing job in keeping people out of the emergency room, keeping people out of the hospital, and all of that, but have gotten hit on some of the drug costs specifically related to this problem of underlying price prediction. And depending on what your mix is of patients, therefore patients on IO drugs, Part B versus Part D, the dynamics are really crazy here, and that's what is not down yet at all and is one of the biggest flaws with the model.